Good morning. My name's Dr. Andrew Hopkinson. I'm the founder of New Vision Biotherapies and the Principal Research Fellow of the Ophthalmology Department at the University of Nottingham. I'd like to start by thanking the conference organisers and SimiMed for the opportunity to talk to you this morning. And what I'm going to be doing is introducing products that SimiMed are going to be bringing into Switzerland. And this is Omnigen and OmniLenz. So it's an amniotic membrane technology that can be used in the theatre or in the clinic using Omni Lens. I'm going to be introducing the scientific background into the development of the products. Mr. Alalfi will follow me with presenting the clinical data that they have generated within their own hospital setting using the products. So amniotic membrane, as most of you probably already know, is part of the sac around the baby during pregnancy, which is disposed of as waste at birth. Amnion can be taken and processed into a material that can be used in multiple fields for tissue regeneration. Amnion's found its home quite nicely in ophthalmology over the last 80 years due to the properties that it can bring, and it can provide a wound healing therapy option when you have ocular surface disease. Because of the duration that Amnion's been available, it's been well published to have proven clinical benefits. And the key benefits that I believe are important are anti-inflammatory properties, its anti-fibrotic and antiogenic properties, and then these combined drive epithelial wound healing. And when you use this in a situation where the patient's in severe pain, it definitely provides a benefit to the patients. So cryopreserved amnion has been widely used for many years, and these are three very nice examples of how it can benefit ophthalmology. So in 2019, there was a meta-analysis published in the amnion transplantation in corneal epithelial defects. And the meta-analysis demonstrated that amniotic membrane transplantation is an effective method for treating corneal ulcers and restoring damaged corneal epithelium. The paper also showed that the amniotic membrane transplantation also reduced inflammation and also the post-operative complications. In 2019, Schursch also published a paper in a very nice, well-structured case series showing the use of amniotic membrane transplantation in non-healing corneal epithelial defects and corneal ulcers that were already refractory to standard of care. And they actually showed that a range of etiologies and that the mean duration of amnion transplantation was between 42 and 46 days. And they actually demonstrated that 70% of the non-healing defects healed and within 1 month. And the most effective etiology that amnion was shown to benefit was in neurotrophic and infective keratitis and hepatic ulcers. In another example, which is not probably widely used, but I think it potentially holds great potential, there was a paper in 2017, and it's a randomized control study in bacterial keratitis. And what the researchers did was they intervened early in the patient pathology within 2 to 5 days. And what they initially did was treated aggressively with antibiotics. And when they saw that the condition was responding, they then went in and transplanted amnion. And the result of this was the patients recovered much easier, and that they demonstrated a significant improvement in visual acuity and reduced neovascularization at 6 months. So amnion has been used for over 80 years, and there's a wealth of clinical data out there. There are over 2 million transplants performed worldwide every year. So I think from the data and from the volume that it's used, you can consider amnion as a safe and effective therapy in ophthalmology. Now, the challenge is that most technologies used historically are over 20 years old. And the way that amnion is preserved is either using, historically, it's cryopreservation or freeze drying or heat drying. And when these were originally developed, little was known on the impact of these preservation techniques on amnion. But what this is resulting in major limitations. So it is now known that these techniques damage the tissue, and that reduces the function. It makes the tissues very difficult to store and ship, particularly cryopreservation. This has reduced benefit and utility in a clinical situation, and because of the challenges faced at accessing Amnion and applying Amnion to the ocular surface, they are generally restricted to surgical situations, and therefore patients that need treatment but are in an outpatient setting don't really have access to Amnion. So although Amnion does work, as we've just seen, there are ways that could make it better. And that's how our research at the University of Nottingham started. So I started my PhD in 1999. One of the first questions that I was asked is, why does Amnion work? What makes it beneficial? And immediately I started using techniques to just visualize the Amnion. And what I was able to show, if you look at these pictures here, is traditionally Amnion was viewed under histology techniques. So sections of Amnion staining, you can see fresh Amnion and cryopreserved Amnion look very similar. But the technique that I used was a very high-powered electron microscope to look down on the surface, and you can see here the fresh Amnion looks like a nice cobbled surface, but the cryopreserved Amnion, there was extensive damage to the tissue. And what we actually showed was that the cryopreservation process that is routinely used for preserved Amnion causes extensive damage through ice crystal formation. And the question that I had then was, if Amnion is visibly damaged by cryopreservation, what other damage does happen to the Amnion in terms of the beneficial function that it had? So immediately I started to look at growth factors. And what we established was Amnion essentially ruptures with the ice crystal formation. And no matter how you preserve Amnion in a frozen state, this is unavoidable. And then when you then thaw Amnion out to use it clinically and prepare it for surgery, this then releases the beneficial proteins into the medium and then lost. And we started to look at growth factors, proteases, cytokines, neurotrophic factors, and important cell adhesion proteins. And what this bar chart shows is the blue is the amount of protein that's lost as a result of cryopreservation. So you could see widespread across the board, many proteins are affected by cryopreservation, some almost totally. So therefore, we concluded that the beneficial effects of Amnion that you currently see were due to the physical mechanisms that Amnion can provide in an ocular surface situation. So we started to question whether we could improve the preparation and the quality of Amnion. And this led to 18 years of research, which resulted in a process that we called at the time the TEREO process. This is broken down into multiple steps. So what we did is we looked at the amniotic membrane process and said, at every stage of the process, do we need it? What does it do? Can we optimize it? And then this became a very, very streamlined and a very effective process. So first of all, we take the amnion and isolate it from the other layers of the placental tissue. We subject it to a very delicate washing process. And the third step, which is a critical step, is on the reverse side of the amnion. If you've ever used amnion surgically, you will know there is a sticky material called a spongy layer. And normally you use that to orientate the amnion. What we actually identified was this material is very difficult to standardize in the amnion, plus also it actually has properties that are inhibitory to cell growth. So in actual fact, spongy layer is an undesirable material to have on the amnion for transplantation. So we developed a way of delicately and effectively removing the spongy layer from the amnion. The next step is that we treat the amnion with an antibiotic solution, which helps decontaminate the tissue, and it's a regulatory requirement. But we also include a protective sugar called raffinose. And what this does is it infuses into the tissue and it protects the tissue during preservation. So there's no damage, doesn't shrink, and it allows the tissue to remain and retain the qualities of amnion following preservation. And then the sixth step, which is also a major step, is that we use a method of dehydrating that doesn't involve freezing, so it's not freeze dried, and it doesn't involve heating, so it's not heat dried. It's actually a vacuum. And the vacuum process delicately removes the water, and because the sugar's there, you result in a tissue that is very, very malleable and is easily rehydratable. And what we've done recently is we've demonstrated that this whole process is a very robust and secure process, in that there is no microbial contamination that comes through this. So we've got the assurance that this product is always clean and sterile. So we have this product. How do we know it's better? So one of the first techniques that we did was we resorted back to our high-powered microscope technique again. And what we did is we looked down on the tissue, so this is scanning, and then we took sections and we looked at the sections using transmission electron microscopy. And I don't really need to tell you much about this image. You can just play a game of Snap, and you can see the top two, which are fresh amnion, look very similar to the bottom two, which is vacuum dried, which we then eventually called Omnigen. So the terminology between vacuum dried and Omnigen will interchange through this presentation. So we can see that the frozen amnion looks very different to the amnions that we were producing. To understand the impact on the structure, we've tried various different techniques to identify and quantify the damage. But one of the most effective is actually creating a drum. So in vivo, Amnion is a bag of liquid protecting the baby. And what we wanted to see is does that retention mechanism work, or is it retained following preservation? What we actually found was in fresh amnion and Omnigen, no liquid passed through the membrane, but in cryopreserved amnion, all the liquid passed through the membrane. So it shows that the membrane is damaged in some respect. And what we actually got to was that the ice crystal formation separates the fibers of the amnion and allows liquid to pass through. We then started to look at the biological benefits or effects of preservation. And we did this in 3 separate phases. First of all, what we did is we took a tissue that had been preserved in different ways, and then we washed that or reanimated that ready for surgery. And what we did was we then collected the tissue and the wash buffers, and then we measured the amount of proteins that were in different preparations and compared them to see what proteins were lost. The second set of experiments was we cultured human corneal epithelial cells in the presence of and on top of amnion. So in this is a culture plate with cells at the bottom, and then there's a piece of amnion hovering above the cells, so they're not in direct contact. Direct contact, we place the cells on top of the amnion in this culture plate. The third experiment was to look at the in vivo benefit or effect of preservation using a preclinical study. And we actually optimized a chemical burn in rabbits, in an acute chemical burn, and then we assessed the benefits of applying amnion immediately after the burn. So when we're looking at the biochemistry retention, what we were able to show was that when you look at fresh amnion, the dark part of the bar is the amount of the protein in the tissue. The light part of the bar is what's coming out of the tissue. And here we looked at EGF, so epidermal growth factor, which is the key wound healing protein for ocular surface and epithelium. And you can see fresh amnion has a lot of the protein in the tissue. It constantly produces it, so you get this elution. When you cryopreserve amnion, you can see there's a dramatic drop of this protein detected in the tissue, and a huge increase in the buffer. So you can see that the amnion is losing the proteins. And in vacuum dried or Omnigen, you can see that there's a slight decrease relative to the tissue, but in actual fact, the retention is very comparable to fresh amnion. And this is just one protein of many that we looked at. So this is representative of what happens in amniotic membrane following preservation. So how do this retention affect performance in the presence of cellular behavior? And we did this in 3 stages. First of all, we looked at how cells grew and proliferated in the presence of amnion. So in these experiments, the grey bars are cryopreserved amnion that you'll routinely use, and the blue bars are our vacuum dried amnion. And what we found was when you grew cells in the presence of amnion, not directly on there, there was hardly any stimulation of proliferation in corneal epithelium. In actual fact, we saw a decrease, which suggested the cells died. But with the vacuum dried amnion, you can see there's a clear, significant increase in proliferation. And this data is actually published. Because this bar went down in cryopreserve, we wanted to see why the cells were dying. So we carried out a cytotoxic assay. And what that means, what that does is measure cell proliferation, cellular death. So bars going up means cell death. And here you can see cryopreserved amnion actually induced cytotoxic death. And we related this to the spongy layer that I've just previously spoke about. But because Omnigen has no spongy layer in the product, there was no cytotoxic effect. Actually, you can see it had an inverse effect. So it's protecting the cells from dying. So we can see there is already a change in cellular behavior to the two preparations of amnion. And what then threw a bit of an interesting output was when we started to look at the regenerative benefits of the tissue. So amnion is known to promote wound healing. We created an in vitro model of cultured cells, and then we injured them with a standard scratch. And what you can then do is assess wound healing by stimulating them with different preparations and see how quick that scratch closed. And what we actually found, compared to the control, cryopreserved amnion had no benefit in terms of wound healing. And you can see here that vacuum dried amnion significantly increased that closure of wounds. So there's definitely a response to wound healing. Taking that into an in vivo model, we only were able to do this in a pilot study, but we created a very clean chemical burn. And you can see here that the burn is very well delineated on the edge of the limbus. The burns that we created, because of our regulatory requirements, had to heal normally, even without treatment. But what we could see is when we created the burn, applied the different preparations of amnion, and monitored healing by measuring wound closure over a period of 48 hours, we could see that both preparations actually increased wound healing. So amnion does have a beneficial effect. The interesting outcome is that cryopreserved also increased wound healing. So this is the benefit that we've talked about before. Our subsequent research, which is not in this presentation, showed that the cells that were regenerating over the surface in cryopreserve were not actually regenerating, they were spreading out. So the wound was closing, but they weren't actually fully regenerating in a normal corneal epithelial architecture. With the vacuum dried amnion, you're getting epithelial regeneration. So from our in vitro and preclinical work, we got an idea that Omnigen would be performing better than cryopreserved, or at least as good. This subsequently then was transferred to New Vision, licensed to New Vision, and this is how Omnigen came about. So Omnigen is tereo-processed amniotic membrane, and it's prepared exactly how we did in our university environment. The benefits of Omnigen or tereo-processed amnion over other amnion technologies is that it's stored at room temperature. It can be stored on the shelf, shipped very easily. It's available at the point of care and can be stored on the shelf within the hospitals. It is designed for both surgical and ambulatory use, which we'll come to in a second. You've got greater accessibility for amnion transplantation, and we provide the products in a range of sizes that provide flexibility to the surgeon, so they do spend less time preparing it, and therefore there's less waste. The way that we use Omnigen is it's applied directly to the surface of the eye from the packet, so apply dry for in vivo rehydration. This rehydrates rapidly in a couple of minutes, and that allows you to then manipulate it very easily at the ocular surface before you actually then secure your membrane down using your sutures or glue. So from a surgical perspective, you use it exactly how you would normal amnion. What we've done is we've taken amnion from the theatre into the clinic. And the way we've done this is using Omni Lens. So Omni Lens is a bandage contact lens that we've had modified very, very slightly to hold amniotic membrane. So you may have tried to use Amnion with a contact lens before. You may get some retention for a period of time, particularly if there's an exposed defect and the corneal stroma sticks to the amnion. But generally, a normal contact lens will not hold amniotic membrane. So we spent a year and a half developing Omni Lens. And what this allows you to do is you can take the amnion from the packet, put it into the lens in the clinic, and then place this on the eye. It takes about 5 to 6 minutes to actually do the whole procedure. Our Omni Lens C, which is our launch lens, is a 16mm lens, so you can see on the outside here. And then this holds a 12mm piece of Omnigen. So the Omnigen sits really snugly on the limbus. The amnion is retained well at the ocular surface. If it does move around under the lens, as long as it's retained and the patient's comfortable, you will still get the wound healing benefits from amnion. In terms of the duration of use, this is a practitioner decision. New Vision cannot give you guidance on the duration of wear, but we recommend following the IFU. But in terms of amnion will last between 7 and 14 days. If it's a high inflammatory situation, the amnion will be spent after 7 days due to absorbing the immune cells. So we provide you with a guide of how to apply it. And it's a very simple guide. The key thing is you have to apply anesthetics to the patient. The reason being is when you first apply Omnigen, it can sting. So we meant to make sure that the patient experience is very, very good. You remove the lens from the bottle, you pick it up with the blunt forceps and give it a shake, place it on the inside lid of the bottle. And what you do then is you place the Omnigen in the right orientation inside the lens. And it's easy to do. If you don't get it right, you can move it around with the forceps quite nicely. Just wait for a minute and then you can apply the lens exactly how you would do a normal contact lens. This is an OCT showing how nicely they both sit and interact at the ocular surface. So you can see the Omni Lens, the amnion, and then the cornea. So taking amnion away from the surgical setting into an outpatient setting and making it a very simple 6-minute procedure opens up the potential of using amnion in a broader range of indications. So you've got point of care access. You can treat, or you can apply this application in almost any environment, and therefore you're getting the benefits of amnion in an early setting. And removing the need for surgery is a cost saving for your practice. And by treating your patients much faster and more effectively, you are able to tackle inflammation earlier, drive wound healing earlier, provide the comfort to the patient, and hopefully minimize nerve damage and drive regeneration. And ultimately, you can turn amnion into a preventative therapy rather than a reactive. And one benefit of this whole strategy is that during the pandemic, when the challenge of treating patients is there, this is an ideal solution. Just to give you a quick update on our latest lens. So we are just about to launch a much larger 18mm lens called Omni Lens L. And this will allow the application of a much larger 18mm amnion disc to the patient. And this will allow a greater profile of the diseases. So just gives you one example of a patient that was treated during COVID. So this patient suffered a chemical burn, quite a severe chemical burn that damaged both the conjunctival region and also the corneal epithelium. Ordinarily, this patient would have been scheduled for surgery, had to wait, the damage would have continued, you would then suffer the surgical damage, and therefore there's a chance that they would have had some long-term problems that needed to be resolved. In this situation, they treated with Omni Lens, and you can see a 1-week treatment, and then the second week was follow-up. The patient's ocular surface was very happy, very stable, and they provided a very good outcome. So with this whole treatment strategy, it opens up the potential for multiple etiologies. So you have your conventional corneal epithelial defects and your keratitis, and your recurrent corneal erosions as your one family. Then you then can start to consider your inflammatory diseases, so chemical burns, SJS, graft versus host disease, and then what we call surgical induced, so following refractive surgery and collagen cross-linking is an area that we're looking into. You can see we've not actually used Omnigen in these yet, but it's an area that we're focusing on. We've got papers coming out, as you'll find out in a minute from Mr. Alalfi, in PEDs, and we've got studies across the range of the different diseases. So it's work that we're committing to. Just a few precautions. Our amnion is produced with antibiotics, so you have to be aware of potential antibiotic sensitivity. We've never had any issues, but it's something you have to assess each patient with potential sensitivity on a case-by-case basis. Always observe potential abnormalities in the corneal topography, which wouldn't be conducive to wearing a bandaged contact lens. Similarly, with eyelids, if they're not going to work well with normal bandaged contact lenses, and patients such as heavy blinkers and rubbers, and even pediatric patients who may rub, you have to consider the suitability for Omni Lens and whether you can do things such as wear shields to prevent the removal. So they're just a few precautions. I'd like to wrap up now and thank you for the opportunity of presenting you today, and we'll then hand over to Mr. Alalfi. Thank you very much.